on the schedule. Real quick announcement, Dr. Bowling made me aware that the Change Talk program that he showed earlier is available as an app to download from...
You just go to the App Store and search for Change Talk. It's free, and it's a great little interactive one. The first version is out. The avatar is great. It's Bob Schwartz, who Ashley and I know, who's like sort of the guru for pediatricians doing MI. There's one, and then the second one's going to be coming out pretty soon. We're just kind of finalizing that right now.
Okay, great. So be on the lookout for that, and be on the lookout for the new one.
And I think it's on the Android platform also. So.
Great, thank you, Dr. Bowling. We'll go ahead and get started with Dr. Weedn's second talk about the comorbidities that you will likely see that come with pediatric obesity.
Okay, thanks, Tim. All right, so we're going to switch gears and go back to talking I'm going to give an overview of all the different medical obesity comorbidities that, to be aware of in primary care. And I think you're probably familiar with most of these. So it's a brief overview. My disclaimer here is that I'm not a pediatric subspecialist. But when I've essentially... when we developed our pediatric weight management clinic, we integrated all the subspecialists into it. So there's a representative from every section who is a part of our program. And so I think what's so key when we're dealing with some of these comorbidities is, I'm fortunate because I'm in an academic center and I have that subspecialist right there. But they provided for me, like for my institute, for Oklahoma, and they wanted me to relay this all out to the primary care providers in Oklahoma, is, when do they really want to see referrals? What kind of initial workup would they like to see primary care providers doing? And so that's really helpful. So, obviously that's going to be different here in Kentucky, but we can hopefully have some interaction, y'all's experiences trying to refer kids, or what management y'all are already doing for things like hypertension and those type of things. So again, please feel free to stop me during this, or even just to say, slow down, be like, hey, we don't have that, what's the recommendation if we don't have that, and we'll chime in and have a discussion about it, okay? No disclosures. The specific learning objectives are to just recognize the various clinical implications of obesity, and then I'm going to focus on both emergent and chronic comorbidities, and then describe the evaluation and what guidelines there are out there. I want to review those and provide those algorithms based off a recent publication, as well as the National Heart, Lung, Blood Institute guidelines for both dyslipidemia and hypertension. So we've I think, beaten this to death, where we know the definitions, overweight and obesity, and the only point here that I want to say is that for a lot of these comorbidities, we're seeing these with, the higher BMI percentile, so over 95th percentile, but even much greater than that. So I left off kind of this definition of severe obesity, and the 2007 recommendations had said a BMI percentile greater than or equal to the 99th percentile. Our clinic, that's the kids that we're kind of targeting for our multidisciplinary clinic. So most of the kids we see really have those pretty severe obesity. So I'm seeing these conditions on a pretty regular basis, even though the prevalence when I show you out in primary care may not be seeing them as much, but just to be aware. So this talk focuses more on the review of systems and physical exam to assess risk for comorbidities. I've already shown this picture, just the breadth of comorbidities and how it really affects every system. So I'm going to briefly walk through each system here. And I'm going to start with the neurological and the pseudotumor cerebri. And again, this isn't debatable. This is just as it is. Some of our obese kids, and this is going to happen more in teenagers, are at higher risk for pseudotumor cerebri. It's for the non-providers out there. It's a raised intracranial pressure with normal cerebrospinal fluid and brain parenchyma. So basically, they have brain hypertension, essentially. The incidence is very rare. So in kids, more rare than in adults, but it's about 0.9 per 100,000 among children. I've seen about 2 in my 4 years at being Oklahoma, both through the ER inpatient side. So typically females, female adolescents who A risk factor is medication, so retinoids. So our obese teenagers maybe with PCOS that have acne and they're taking retinoids, and so that's been linked with pseudotumors. So just being aware of that when you're seeing these kids. The symptoms are headaches and vomiting, visual changes, although in children they may not recognize the visual changes, and if you're not doing visual fields tests, that may not be picked up. So it's really the signs of intracranial pressure. So the headache, the positional headache when they're sleeping, or if they wake up with a morning headache or vomiting. Again, pretty rare because I see a lot of kids that are obese that present with headaches. But I'm really looking for that positional headache and vomiting. So what we would be looking for as family practitioners and pediatricians, if we saw a kid that had a headache and vomiting, we would be going and getting some imaging for that. So that's the same case here. If I have a kid that I'm concerned that's reporting morning headaches, I do a fundoscopic exam because I want to see if I can see any papilledema on them. Although there's been studies out saying that kids may not even present with the same range of papilledema. And for the non-providers, the papilledema is in this picture here. It's just blurred optic disc margins here. So the diagnosis, you want to get imaging to make sure there's no mass in the head, or so there's no brain parenchyma involvement. But the diagnosis is by a lumbar puncture, and it's a high pressure. And then the management is I send right off to emergently to neurology. If I have any concerns about the papilledema, I also co-refer to ophthalmology. They usually start them on acetazolamide and do serial lumbar punctures. But underlying, we're doing weight control at the same time. I think I mention it even though it's not very common because if it does pop up, this is one of those emergent comorbidities that can, if it's not addressed in a timely fashion, can lead to visual impairment and blindness in about 10% of kids. So the key points then would be to ask about the occurrence of headaches, especially among obese pubertal girls, and then performing a fundoscopic exam if you have an obese child that presents with headache, morning headaches or headaches worse with lying down, or any nausea, vomiting with the headaches. So moving to the musculoskeletal system. Providers, the two kind of more emergent musculoskeletal conditions to address are slipped capital femoral epiphysis, and that's just basically displacement of the femoral epiphysis into the metaphysis. But basically, your hip bone is being displaced, and so that causes a limp. It's not very common either, but we see a handful of it. About 1 in 10,000 or 11 in 100,000. Risk factors, early adolescence in boys. So if you have an obese kid, a pretty severe obese kid that's coming in with a limp, this is what you should be thinking about. I have seen some kids that haven't had the limp but have had pretty concerning like groin, thigh, aching pain. They didn't have any trauma. They had limited on exam, like limited range of motion. I work with a physical therapist in our multidisciplinary clinic, so she, kind of confirms. She's like, yeah, so we go ahead and get frog legs of it because in 20% of the time it can be bilateral, and to try to make that diagnosis. And early on, you'll just see a widening of the joint space before the complete posterior displacement. So I think it is worth, if you have any concerns or there's range of motion, hip range of motion is not normal, to go ahead and get those x-rays, and then an orthopedics referral as well. So Blount's disease is a deformity resulting from disruption of normal cartilage growth basically at the knee, so for the proximal tibial physis. It also is about 1 in 10,000 children. I feel like I see this pretty frequently. So kids are usually referred to us after it. It happens in 2 to 4 year old children. I say frequently. I may see like 1 a month or 1 every couple of months. But it definitely is something. It's the bowed legs that you see in the little kids that becomes pathologic. So it's age, but we continue to see it even after the preschool age years. We see it in adolescence. Even just a little bit of mild varus, so that bowing, can cause growth retardation of the cartilage, which can lead to ultimately deformity. So the exam finding is, y'all have seen those pictures of the legs with the bowed legs. And so, there's normal bowing and then there's pathologic. And so if that's persisting past the age of 3, if it's progressive, if it's pretty spaced out apart, going ahead and getting full lower extremity x-rays from the hip to the foot can help. They'll look at the degree and the angle on the x-ray, the radiologist will. And so if it's past like a 16 degree, which they'll say in the report, to go ahead and refer to orthopedics. Depending on their age, the management kind of depends on their age. If it's mild and not severe, a lot of times they'll put them in braces first, or they'll just send to us for weight control. So I often get referrals from orthopedics, which is maybe why I see it more, is they'll send them for weight control before doing the surgery because it's maybe a mild bounce before it gets to the where they're concerned that it's going to cause deformity. Frequently, though, those kids will go ahead and get surgery so that they're not having a long-term deformity or leg length discrepancy. The more common musculoskeletal conditions, my slides don't work, are ankle, a lot of, with the excess weight, ankle instability and pain and sprains. And so I really take a good history on that on exam, and then look at strength in the ankles and get PT involved pretty quickly, because same thing with foot pain. If they're complaining about foot pain, if they're saying that they have foot pain when they're walking, then for me to sit there and say, oh, you need to go walk, an hour a day with your family, if it's hurting them, how likely are they going to do it? And furthermore, that may be making their makes them not a big fan of doing the activity when they're hurting, but I don't want to cause problems long term. So we have a lot of kids, just the pathophysiology is they have more flat feet. So we'll do orthotics referral for them, or for the ankle stability, our physical therapist will give them exercises, which you can find online for ankle strengthening, and it really does help. So like within the next couple of visits, they feel better and they're able to walk longer. I don't know if y'all have what the PT resources are here at all. Do y'all have good physical therapy resources that y'all? Okay, all right. So that's and the orthotics as well. So kind of the key points for there is to do a thorough hip, knee, ankle, and foot pain, and I feel like should be a part of every evaluation. And then following that child who is complaining of pain, or if they have an abnormal gait, that needs to be looked at right away. For obese children with musculoskeletal complaints, just the caution in recommending certain types of exercise before exam or before referring to physical therapy. So, so some of our kids that have severe obesity, morbidly obese, and have such pain walking or back pain or whatnot, we'll start them sometimes with their activity just sitting on a stability ball. Like that is their activity is, well, let's go to sit on the stability ball, for 30 minutes at a time and work on that core strength. And that's their activity goal. And so I think just being mindful of when we're talking about activity, and this is really more for the severe obese kid than kind of the mild obese kid. Any questions at this point? Or just as y'all have questions, please feel free to interrupt me. So moving to the pulmonary system, obstructive sleep apnea. So this is, disordered breathing characterized by prolonged partial upper airway obstruction, and that disrupts normal sleep patterns. So it's disruptive sleep. It's associated with obesity. I would say, so we actually just looked this up because we're starting a weight management clinic in rural Oklahoma that don't have any subspecialists nearby. And so we're working with them. And they said, well, how often do you see sleep apnea? And I reported here what's in the literature, between 37 and 59% of obese kids, so over the 95th percentile, have sleep apnea. We reviewed our records, and for our new patients, over 60% are I am needing to get a sleep study on because they've either, a lot of times by the time they're referred to stage 3, they've already had, a TNA done, but even if not, I'm usually getting a baseline sleep study as well. So we use that frequently, and so their hospital is now looking at trying to get sleep studies for instead of referring everything to the city to try to do that. That being said, I mean, if you have a kid who's got tonsillar hypertrophy, it's obvious on exam, and they haven't had a TNA. You know, the AAP American Academy of Pediatrics, they have a policy statement on obstructive sleep apnea, and it's referred to the ENT doctor. Have them assess if they feel like, you know, I can only assess tonsils. They're going to assess adenoids as well, and so they will typically do a TNA. Even without the sleep study. The management, also in those policies, you can do intranasal steroids to help decrease any inflammation if it's in the upper airway, referral to ENT if they don't, if they have their tonsils or adenoids intact, and then referral for us in the academic center, I refer often to our sleep medicine specialist, because once I have a sleep study, and the diagnosis here, I said an apnea-hypopnea index of greater than 1 in kids. So that's pretty low. So in our teenagers, I really depend on some. In our teenagers, the adult cutoffs are 5, and so we'll really look at how symptomatic they are. But I have 4 and 5-year-olds that have an AHI of like 8 to 12, and so I have to have them on CPAP. It's not a choice. So it's like trying to find them, and getting child life involved, because wearing CPAP in a 4-year, there's complications. It's hard to do as an adult, and so kind of having that team involvement has been helpful. And Dr. Bowling was saying that there's sleep medicine is at Lexington. Is there sleep medicine at Lexington?
Lexington and at Cincinnati.
And at Cincinnati. So, in Cincinnati, do they do some satellite clinics?
So yeah, so for sleep, they don't come yet to Maysville, but for a lot of the other things, they do come to Maysville.
Okay. Just trying to think of resources as far as, who would be able to do your sleep studies. And I mean, for those of y'all, that are already here, I don't know if y'all send out for sleep studies. Oh, fantastic. Very good. So I can move on. And long-term complications of hypertension. So key points are just making sure to obtain a detailed sleep history, which I apparently skipped over last time. Snoring, irregular breathing, pauses, gasping, daytime fatigue. And so I ask all the questions. I say, do you ever fall asleep in the classroom? Do you fall asleep on the bus? Do you fall asleep when driving to this appointment? Because sometimes the kids are, driving 30 minutes to the appointment. Are you having any concentration problems at school? Are there behavioral issues in our, especially this really is pertinent in kids where they have some neurocognitive problems, and so behavioral issues. And several after treating that the sleep apnea, they start to see improvement. Now it's hard because you're evaluating for ADHD and anxiety and depression, so you've got to kind of keep all of it. So I'm looking for a cluster of symptoms. I also ask about headache and nighttime bedwetting as well. So all of those are kind of symptoms of sleep apnea. So key points is obtaining that detailed sleep history on obese children and asking specifically about, sleep disturbances, snoring, and how their sleep position is, and remembering to, if they're having poor school performance or concentration difficulties, to have a sleep apnea for an obese child kind of on your differential diagnosis. So asthma. So obesity is associated with asthma, and actually the relationship is somewhat unclear. When I was a resident in the weight management clinics, I just assumed that obese kids, they already had asthma, and that's why they were obese, because they're maybe not doing as much activity, because a lot of times parents will restrict activity because, I don't want to flare up their asthma. And so, but actually, there's some data to say, hey, actually obesity can be a risk factor for asthma, and so that can be a comorbidity of asthma. So there was a study in California in the 90s that looked at 4,000 children in the Kaiser institution, and basically these obese children that were having new onset asthma with an incident rate of, new onset of like 31, with boys having higher incidence than girls. So I always do. So if I'm being referred a child, an obese child, and there's no asthma in their medical history, because I get all kinds of primary care provider's notes because I really want to know what's happening with the child and the primary care provider before they come. And I review all of those. And so if I don't see asthma anywhere in their problem list, I'm still double checking that, asking about that. And I'm surprised by the amount that, oh yeah, when they're pretty active, they are coughing, you know. And so I am kind of aggressively trying to manage that to optimize it. So the symptoms, wheeze, cough, really with activity, chest pain, that tightening, if it's altering their activity patterns, are slowing them down. And so it's not necessarily shortness of breath. You know, they're out biking and shortness of breath. I mean, that can be an endurance issue, but they're also coughing a lot. And then parents sometimes will not report a wheeze. We'll do a trial of albuterol, and it makes a huge difference. I don't ever, the exam finding of wheezing, I don't usually find that because they're not actively. I will say that we have kids that have not been diagnosed with asthma that when we do our treadmill testing with them in our multidisciplinary clinic, they are wheezing and they are coughing, and they have had no diagnosis of asthma. So that is why I'm really paying attention, because I get to see them when they're exerting themselves, and so that's an advantage I have as a provider. So I'm trying to get that history. And if need, I'll put back to the PCP note, you know, consider pulmonary function test if the child's old enough. And I will say that I've gone ahead and done an albuterol trial, and then I turn it back over to the PCP, follow up with PCP for asthma. And I just kind of, because I don't want to step on their grounds per se, but I will just make some suggestions in the notes. So key points are obese children, if they're inactive, may not report symptoms unless specifically asked, so ask. And as exercise increases, symptoms may emerge. So moving to GI, I'm going to start, So non-alcoholic fatty liver disease, NAFLD, is on the rise. So it's an accumulation of macrovesicular fat in the hepatocytes. So it's actually also another pretty common comorbidity. So looking at kids in NHANES, the National Health and Nutrition Examination Survey in 2007 to 2010, they looked to see on the LFTs, the ALT specifically, how many kids had elevated ALTs. And so of kids who were obese. And so of the obese females, it was 27% that had elevated ALTs, and almost half, like I had to read that study a couple of times, almost half had elevated LFTs for boys. Now, I went back and looked to see what their cutoff points were, because I was like, I don't feel like I'm seeing half. But it was, and LFTs are not great, they don't have a great sensitivity and specificity anyway, as well. So, but they set their cut points per the GI recommendations, more of 25 and 28, because, you know, the lab varies. Every individual lab varies. And so that may not have been picked. You know, our lab picks it up at 44, I think, for an ALT. So, but it is common. It progresses to hepatitis in about 20% of obese children. And then the risk factors, minorities are at higher risk, males are at higher risk. Again, this is not something you're going to have any symptoms of. I mean, few people actually complain of abdominal pain for fatty liver. Sometimes that's how it's picked up, though, is you'll be thinking, oh, it's gallbladder, I'm going to get an ultrasound, and they come back with fatty liver on ultrasound. I do, and about half of my kids with fatty liver, I can feel their liver. And so I always make sure that I'm looking for that on exam. The screening labs are the AST and ALT. And then fatty, go ahead and doing an ultrasound and actually seeing that. The diagnosis is actually, the gold standard it's by biopsy, but in reality what we do is we rule out every other cause of liver etiology. And if they've got, you know, if they fit the criteria, if they've got the elevated LFTs and they're obese and there's not another reason for that, then, you know, that's when we make the diagnosis in the ultrasound. So for the management is weight control, with focusing on decreasing specifically sugar, fructose, and trans fats from diet. When to refer these kids to GI, it kind of depends on, you know, where you're at, what the institution takes, but a lot of guidelines will say if the ALT is over 100, and the complications, of course, is that it's correlated, it's part of metabolic syndrome, and that this is, NAFLD's expected to kind of replace, it leads to cirrhosis. So they predict this is going to be the #1 cause of liver transplants in like 20 years. It's also an independent risk factor for cardiovascular disease. And again, that's because of the kind of metabolic condition, what's going on in that kid's food environment. There have been studies that looked at, is maybe management with vitamin E or metformin, and that's kind of equivocal right now. So some places are doing it, some places aren't. The recommendations, there's a this source right here, Children's Hospital Association consensus statements for comorbidities of childhood obesity. So these are kind of pediatric experts from 25 or 26 of the Children's Hospital Association that got together to say, hey, there's no guidelines on what I should be doing with these kids with all these chronic conditions. And so they kind of put together in a consensus statement of, here's working with their specialist and at their own programs, what recommended kind of management is. So I know these are hard to read on the slides, but I just wanted to let you know that there are algorithms out there for a lot of these conditions and have the resource here. But basically, they say the same thing. So if it's 40 to 60 elevated, continue to monitor by labs and focus on your weight management. Specifically kind of targeting the same types of for insulin resistance, getting rid of the sugars. If it's 60 to 100, if you don't have a GI specialist next door or a fatty liver clinic next door like I do, you could go ahead and even start the workup for, is it viral hepatitis? Is there alpha-1 antitrypsin? Is there autoimmune hepatitis? So it recommends what labs you could do to kind of rule out other etiology if it stays elevated at 60 to 100. Again, if it's over 100, they go ahead and recommend GI consult. If you come down this pathway and you're just kind of monitoring it and it's consistently staying above 60, then referring to GI consult. And that's what we do. We monitor it on our own, and then if it bumps up and it's not improving, then we refer to GI. We actually have a pretty good, the LFTs, they respond to the weight management. And so this is one of the markers I use at those 6-month labs. When I repeat labs at 6 months, the LFTs are going down. And so it's great feedback to give parents when they're really trying to make a difference, to see those changes in the labs. Gallbladder disease, that's increased risk in obese kids, particularly female adolescents who are on birth control. Again, providers here, it's abdominal pain, potential nausea, vomiting, fatty food intolerance. But I swear, the 4 kids that I've seen that have had gallbladders did not present. They had some abdominal pain, but they didn't have right upper quadrant tenderness on exam, and they didn't give the history of its worth with certain types of foods, and so we just we got the ultrasound, and there it was, and referral to surgery. So I just have it on if they have abdominal pain. Constipation is usually the most frequent cause, but just have it on your differential that in obese adolescents that this could be something that you're seeing even without having the typical history or exam findings. So moving to endocrine. Insulin resistance. Okay, so prevalence of this is, we think, pretty high in obese kids. So 20%, in one New England Journal of Medicine study, 20% of obese children have an impaired fasting glucose and 25% have an impaired glucose tolerance. Kids, obviously, that are obese have higher odds of hyperinsulinemia than non-obese kids. The risk factors here are minority populations, if they've had, a mom with gestational diabetes, especially when at the time that they were pregnant with the child, our family history of type 2 diabetes in a first or second degree relative. It's asymptomatic. I mean, a lot of our kids have polyphagia, right? They have an increased appetite. So I don't really look at that as much as, I feel like this is pretty asymptomatic unless they've got overt diabetes. The exam findings, you can see acanthosis on exam, as for the non-providers, as demonstrated here. It's just darkening of your skin tissue on your neck or under your arms or in areas where your skin overlaps. So the diagnosis is controversial about this. So there's no consensus statement on this. So I've worked in weight management clinics that were run by endocrinologists and that were run by general pediatricians, and they both kind of agree. There's no specific consensus, but essentially, as far as what testing to do, to call it insulin resistance, like what's the best test for insulin resistance? Because we know the best test isn't clinically available. It's the clamp that you do in research settings. So what we use, what AAP has put forth as a recommendation, is go ahead and get the fasting glucose in kids starting at age 10. We're really not seeing type 2 diabetes, except in American Indian kids before age 10. In American Indian kids, we are seeing type 2 diabetes before age 10. The A1C, the Endocrine Society and the ADA came out saying, yes, we can go ahead and start using A1C in kids a couple of years ago. So you can look at that, although it's pretty variable in kids as well. Glucose tolerance, no one necessarily endorses. So there's Endocrine Society recommendations and there's American Academy of Pediatrics recommendations on what to use for diagnosis of insulin resistance. And so OGT isn't on either of those lists. So I use it in endocrinology. Again, I was trained also by endocrinology. I use it if they have every risk factor. They're over the age of 10, usually teenager. They've got family history. They're American Indian or Hispanic. They've got acanthosis on exam. If it's a girl, if they've got PCOS, that's kind of when I use it. So I certainly don't use this in every obese kids. I use it really in what I consider the highest risk kids. And we do pick up glucose intolerance on some of these kids. And I think that does change my management a little bit when they're that much closer to diabetes. So here is kind of the progression from euglycemia to type 2 diabetes. So the fasting glucose level from 100 to 125, the impaired fasting glucose, and the impaired glucose tolerance between, so a 2-hour glucose on the OGTT between 140 and 199 is the kind of what is considered insulin resistance. RA1C between 5.7 and 6.4. So why is it important? Obviously, the progression to type 2 diabetes. Of those that have hyperinsulinemia, 35% to progress to diabetes. Of those that have impaired fasting glucose, about 38% of those progress to diabetes. 45% of our newly diagnosed diabetes, kids with diabetes, have type 2 diabetes, especially if they've had rapid weight gain in early childhood. And notice I put insulin level on here, but I didn't say anything about insulin level on that previous slide. And that's because that is not necessarily recommended either, because insulin levels can vary so much. So you can be hyperinsulinemic, but as you start to be more insulin resistant, the insulin can go back down to normal, and then you're getting kind of a false. So again, working with endocrinology, they're like, we wouldn't get an insulin level unless you know what you're doing with it, and it's hard to know what to do with it. So right now, it is not being recommended by either society. So the key point here is we do this, we have these conversations because this is all reversible right now with weight control. And again, it offers that opportunity to discuss health risk of lifestyle behaviors with families. So, a lot of the kids that I see, the families, if they have a family history of type 2 diabetes, that's why they're in my office. That's what has intrinsically motivated them to come and let's figure out how to do some intensive weight management. And so they want to know what their child's risk is. And so I'm trying to assess that risk from every angle, from family history to prenatal factors to really what's going on with the kid. And so I do want to give them some level of feedback, which is why I go ahead and get kind of that fasting glucose and an A1C. And then kind of watch those over time. So polycystic ovarian syndrome, we see this quite a bit in adolescent girls. So for risk factors, I kind of ask the mom of my adolescent girls if they've ever, what their menstrual histories are like, because we know that this is highly genetic. I was going to say, I think it was like one of the endocrinologists who told me about 80% heritability, and so that's highly genetic. So I ask about the mom's menstrual periods, if she had any problems with infertility, even if that child is, not quite, is still not pubertal yet. I just like to have an idea as far as risk factors, so I know what to watch for. Symptoms are menstrual irregularity, and it's, of course, timing is important. So I always want to know the date, that their menstrual, when menses started, and then look to kind of 2 years after that. And if they're still having irregular cycles, then that's really when I focus with it. So a lot of times, I'll have a family history. The mom was like, oh yeah. Sometimes the mom knows she has PCOS. Half the time the mom doesn't know she has PCOS. And so she'll be, but if they do, it's like, oh yeah, well, let's go ahead and get her tested right now. And she's like still prepubertal. And I'm like, well, we can talk about it, and this is something we're going to follow, but I'm not going to, it's a clinical diagnosis. You have to have the irregular cycles, after 2 years, and other exam findings, and so I'm not going to try to push that. I say that's something we're going to continue to watch, and we have really good longitudinal follow-up. So our kids that we're seeing 3 years out, the mom is remembering, being like, okay, is she ready now? She's 2 years, and so we'll have that conversation. I have the kids start tracking their periods starting after 2 years of menses. I use the Endocrine Society recommendations as far as for diagnosis. That's the Rotterdam criteria, the presence of 2 out of 3. So some type of hyperandrogenism, and that can be clinical or biochemical. So you don't actually have to have the lab test to do it, but PCOS is a diagnosis of exclusion, so we go ahead and get the lab test for it. So clinical on exam, acne, or more commonly the hirsutism. So if they have hair growth, upper lip, chin. Commonly in the adolescent girls, it's more on the abdomen, which really can be really dark on the abdomen. Then that is part of the clinical diagnosis for PCOS. Ovulatory dysfunction, I already talked about. They can have polycystic ovaries on pelvic ultrasound. And honestly, at our institution, we're not doing that. If they have 2 of the 3, they've met the criteria. And so I'm not sending a lot of these kids for pelvic ultrasounds and kind of traumatizing them that way. That is based off my own institution. That's in conjunction with adolescent medicine, endocrine, and our OB service is why we don't go ahead and get the ultrasounds. But that is part of the diagnostic workup. If they don't, maybe they don't have, they have irregular menses, but they don't have a clinical or biochemical sign of increased androgens, and you feel strongly that this would be helpful diagnosis, or they want to know. I mentioned it's a diagnosis of exclusion, so we get lab work to rule out other causes of hyperandrogenism, and then the management is oral contraceptive pills, weight control, plus or minus metformin if they have glucose intolerance with PCOS, because PCOS is a risk factor for diabetes. Referral to endocrinology or adolescent medicine as needed. So typically it's weight management and birth control. So as the primary care provider, if you're doing that, then not necessarily needing to refer out. The complications are it's associated with type 2 diabetes. It's also associated with HS, hidradenitis suppurativa. So I have a ton of adolescent girls that have get these lesions and abscesses in their axilla and groins, and they're like, what's going on, and all of that. They are hyperinsulinemic, and they are and starting to get insulin resistant, and they have PCOS. So having that diagnosis in place gives me, I'm going to refer to dermatology. I try to treat that with topical clindamycin first, and for some kids that works great, and so it controls the lesions, but for kids that continue to have issues, I go ahead and refer to dermatology, and they've been doing Humira and some other medications that I don't prescribe regularly. And then and infertility is a long-term complication. So again, this is the consensus statements that I mentioned for the by the Children's Hospital Association. So irregular menses up here. For 2 years following onset of menses, and or signs of hirsutism and acne, going ahead and working this up. And so the bolded labs are those that they recommend. Our institution recommends a few different ones, but the reason is just to rule out other causes of irregular menses. So if they have congenital adrenal hyperplasia, or they have ovarian insufficiency, or an adrenal tumor, ovarian tumor, then you want to know that, so you're getting the test for that. The diagnosis, the biochemical diagnosis is a high free testosterone, not total, but a free testosterone, so you've got to have a lab that can do that for you, and a low sex hormone binding globulin are really the main markers if you're going to make a biochemical diagnosis. So wrapping up and moving towards our cardiovascular system. So dyslipidemia. So these are what I feel like is the most common. This is what I see, in primary care on a regular basis. So 39% in JAMA Pediatrics article of children who have dyslipidemia. I would say, obviously, in my weight management clinic, it's higher because I'm getting kind of the more severe obese kids. But it's the most common lipid abnormality in obese children is the high triglyceride level and the low HDL, which is termed atherogenic dyslipidemia. And we know that this really accelerates atherosclerosis and causes cardiovascular disease in adults. So that's the main dyslipidemia. We also see, high LDL levels as well, but not nearly as often. The high triglycerides are, in our preschool age children. I see more of the high LDLs in our adolescent population. So it's asymptomatic. There's no exam findings, which is why you have to that's why it's recommended to do the lipid panel starting from the American Heart Association starting at age 2, from the American Academy of Pediatrics starting at age 10. Abnormal is an LDL greater than or equal to 130, HDL less than 40, and triglycerides, it depends on their age. The 5210 chart that you have as a part of your package actually gives more specific age cut points for triglycerides. I'm not good at memorizing like 7-year-old versus 8-year-old, so I just kind of, if the triglycerides are over 100 and they're less than 10 years of age, they've got high triglycerides. If they're over 130 and if they're 10 years of age or older, then it's a triglyceride level greater than or equal to 130. The management is diet, activity, and depending on how high they are. So if you do see that rare kid that has an LDL greater than 250 or a triglyceride level of 500, going ahead and referring them. I have not had one. When I did have one, it was familial hypercholesterolemia. I usually repeat if I see a triglyceride level, even on my referrals, like when I'm reviewing the referrals and I see a triglyceride level of like 400, I have them repeat that before they ever come in, just to see where we are and if I need to do a more prompt referral before seeing them in clinic. So this algorithm is from the National Heart Lung Blood Institute. It's not from the consensus statements. It is what came out, I think, at the end of 2011, 2012. So it's on the NHLBI website. It's also, it was summarized in a pediatrics article. I have the reference as a part of the slides. But here is kind of the algorithm management. And I'm going to focus on triglyceride level here. But basically, if it's over 100 and they're less than 10 years of age, or if it's over 130, over 100, less than 10, over 130, 10 to 19, then you're going to go ahead and do 6 months of intensive lifestyle management. They recommend the healthy lifestyle combined dyslipidemia diet, which is what we've talked about. It's decreased refined carbohydrate intakes. It's replacing the kind of the simple sugars and all the processed foods with whole grains and vegetables and fruit, and avoiding sugar-sweetened beverages, avoiding trans fats, limiting saturated fats, and increasing fish consumption, which really goes over well with a lot of the kids. So I don't per se. Have you ever smelled the fish oil? It is not the best. Yeah, it's like it is not the best smell. So I really don't. I don't recommend fish oil on initial visit unless it's over 500, and I'm sending them anyway to a specialist if it's over 500. The rate of return on getting if they're doing intensive management, lifestyle management, I'm getting those triglycerides down by that. So I don't feel like I need to add fish oil. But basically, if it's greater than or equal to 200, you can consider omega-3 fish oil as treatment if you don't feel like that family is going to be responding to in intensive management. And then below that, you're just continuing to monitor it over the next 6 months. This is for, I was going to say if there's anything else. Oh, I will say that when I have these diagnoses, sometimes, so I've gone in and I've talked to them kind of about their labs and the medical management. And so when the dietitian comes in, sometimes that will help guide some of the, like what goals they pick. And so Dr. Gillespie's going to follow this up with goals afterwards. But sometimes the parents may be more motivated to target sugary beverages or something else if they have those. So I do think labs can sometimes guide the family in what goal they want to choose. Obviously, you have multiple to choose from if they have high triglycerides. So sometimes if they really don't have a goal listed, our dietitian will say, well, here are all these different options if our outcome is to try to decrease those triglycerides. And then they come back and be like, okay, well, I think I can do this one. So I will say it does help guide our management to some degree. With LDL, again, you want to, so fasting lipid panel, if it's high, you want to repeat it. But if it's over 250, and at our institution, our endocrinologist wants to see them if it's over 190. So again, that's why I say it's institution dependent. But the guidelines say if it's over 250, to go ahead and send to a lipid specialist. If it's abnormals greater than or equal to 130, and so basically at that point you're going to be doing dietary management. You also want to rule out secondary causes of hyperlipidemia, hypothyroidism and medications, but a lot of the kids aren't on these medications. So you're going to do intensive lifestyle management. And then with this box, and I don't know how well you can see it, basically says when would you move? So there was a question earlier, it was like, do you ever put kids on statins? And so when would you move to a statin? So here we are. So it's been 6 months, since they've seen me. They've made goals. So example, a couple weeks ago, had a kid, had an LDL of 164. We've been doing intensive weight management with him. He comes back, his LDL is 145. So this is not the typical kid. This is the kid that I said had a BMI of 95, not a percentile of BMI. So you do it based off risk factors. So if they're over 190, if the LDL is over 190, then the recommendation is to start a statin. If it's between 160 and less than 190, then you're going to look at how many risk factors they have. And same thing if it's between 130 and 160, it's dependent on the risk factors. And so those risk factors are listed right here. So if you have a family history of an MI or sudden cardiac death, and a first-degree relative based off age for males and females, and then there's what we call, they've called high-level risk factors and moderate risk factors. And this was all new terminology to me when these NHLBI guidelines came out, because it's a lot to digest, and I don't know how to simplify it. This is, but basically the high-level risk factors is the more severe obesity, and it's actually hypertension that requires drug therapy, as well as if they smoke, so asking about smoking, and then if they already have type 2 diabetes, or they have had chronic kidney disease for some other reason, or if they have had Kawasaki's in the past. So I mean, I always have to look these up, honestly. I remember these. I don't necessarily remember these other things. And the moderate risk factors are, they have elevated blood pressure, but they're not on any drug therapy. They have low HDL. They have other conditions that are their obesity, but they're not severely obese. And so what it basically says is, if it's 145 and they have 2 high-level risk factors, or 1 high-level and 2 moderate, then go ahead and consider starting the statin. If they are 160, it's only 1 high-level risk factor or 2 moderate risk factors. So the kid came back, his LDL had dropped from 164 to 145. So here he is in this zone right here, between 130 and 160, and I'm like, okay, what do I need to do? So I look at his risk factors. He's over the 97th percentile. He's on hypertension, on enalapril, and so we're going to go ahead and start him on a statin. And so the key points here are to obtain a lipid panel as part of the obesity assessment, to do the dietary management. I think Doing that in conjunction with the RD is really critical. There are actually recommended, so for the dyslipidemia and hypertension, there's something called the CHILD diet, and I always forget what it stands for, child coordinate, it's in here somewhere. But it's basically, it's healthy, it's everything we talked about as far as healthy management, but they also set guidelines on, what percent saturated fat. So it's, for child 1, it's less than 8% of your total calories should be saturated fat. If it's child 2, it's less than 7%. And they also have cholesterol with it. So, having a dietitian involved with that, even though we don't do calories, it's having someone really tease out, how much saturated fat they're getting and getting a good history on that, I think can be helpful. Again, this is reversible with weight control and lifestyle factors. And so that's what I emphasize with the parents when I'm seeing them for that first time. I already have their labs, then I'm reviewing that with them. And that's what we set as our outcome. And then hypertension. So 20% of obese children have elevated blood pressures. The symptoms, it's usually asymptomatic. I've seen headaches with some of my hypertensive kids. You have to look for blurred vision, dizziness. Again, you're going to get this on your vital signs. I think the key here is making sure that you're getting an appropriate blood pressure, that your staff is, and making sure it's the right size of the cuff, because for a lot of our obese kids, they have to go up a size in the cuff. So, I have to do thigh cuffs on a lot of my severe obese kids. I've even had to do like wrist cuffs because the kid with a BMI of 95, I can't get it even with a thigh cuff. So, so we determine the blood pressure percentiles from the blood pressure charts for gender, age, and height percentile. So yet more charts to look at. This is included in that flip chart that was given out if you're not familiar with it. So in kids, we don't do the 120/80. We do it based off a percentile of the blood pressure percentile, and that is based off the kid's gender, age, and height percentile. And I think it's a rather lengthy process if your EMR doesn't do this for you. Do any of y'all have EMR that automatically calculate the blood pressure percentile when you do a blood pressure? Anyone?
It will when we upgrade in a couple weeks.
Okay, there you go. Because I will say, every single referral that I get from around the state of Oklahoma, no one has, I always see a blood pressure, but no one has the blood pressure percentile. Ours is built into it, and it makes it so nice. Because otherwise, how are you going to know that, 108 is elevated systolic blood pressure without looking at that chart? They're like 5-page charts that you have to look at. But the definitions are if it's greater or equal to the 90th blood pressure percentile, that's pre-hypertension. Greater than or equal to the 95th is stage 1, and then greater or equal to the 99th plus 5 millimeters of mercury is stage 2 hypertension. So the key things here is confirming. So if you do automatic, if you do the machine blood pressure, then making sure you get a manual blood pressure, you repeat that blood pressure 3 different times. We do it 3 different times right there. We do it about 15 minutes apart, and we average the measurements and then look and see what the blood pressure percentile is right then. If it is high, you want to rule out secondary causes. So this is particularly true if it's that stage 2, but I also do it for stage 1. Is I go ahead, especially if they're prepubertal, then I will go ahead and look at secondary causes. I'll just get a CBC, a BMP, and a UA real quick. Now, if it persists and I'm having continued elevated blood pressures, then the recommendation then is to refer to cardiology or nephrology or whoever your resource is to assist with pharmacology. When you're in, for my primary care physicians who are in the middle of Oklahoma, or you don't have someone right there, the consensus guidelines that came out for common comorbidities by the Children's Hospital Association, part of that was to help guide primary care providers to say, hey, you can go ahead and start, if you're following this algorithm, you can go ahead and start an ACE inhibitor or something and not necessarily wait for that referral. So it just gives guidelines for that. And that's this algorithm right here. And it's lengthy, but basically, if it's over the 99th blood pressure percentile, then repeating pretty quickly, making sure that you're doing an accurate blood pressure. It goes through kind of the 40% of mid-arm circumference, and the bladder of the cuff is 80% of the arm circumference. And so if you're getting accurate, if you're doing manuals, if you're averaging it 3 times, you're quickly following up on that. And then you're going to go ahead and rule out, do weight management. I go ahead and rule out secondary causes, but if it's above the 99th percentile, going ahead and starting that management. We see a lot of sleep apnea associated, so I'll have diastolic hypertension, but not necessarily systolic. So I'm also trying to make sure the sleep apnea is managed, so that maybe I cannot have to start them on a blood pressure medicine. So if I can get that sleep apnea managed, then I'm not having to put them on a medicine. So I kind of do all this in conjunction. And then if it's stage 1 hypertension, you're following down the algorithm here. You're ruling out secondary causes, and you're doing weight management. So treatment also, as far as dietary, it's also looking at low salt as well. But really, it's kind of that follow-up, regular follow-up, averaging those blood pressures, and if they're continuing to stay elevated, then to go ahead and look for other causes and treat those, such as sleep apnea, but going ahead and starting some blood pressure management or medication. This table was recommended by our cardiologist for our primary care providers in Oklahoma, so that they didn't have to go through those 5 pages to look at the blood pressure percentile. So we have our primary care providers put this at the nurse's station when they're doing the triage, and it basically, if the kid is 3 and they're systolic, if it's a boy, is 100. If they're 100, then that basically tells them, go look at those charts and see what percentile it is. So they kind of did a quick and dirty way to say, this may be elevated, and now you need to go check on those blood pressure charts, rather than having to do those blood pressure charts on every single kid. When it's hard to tell when it's, as you start to get adolescent, you'd be able to tell, but for the younger kids, knowing when to actually look for elevated blood pressure. So our primary care providers have actually really liked having this, since the EMR doesn't have that, and they just have it in the triage area, and that way they don't have to look on every kid. They just look when this is elevated. And this was a study done by Pediatrics. And then hypertension leads to LVH, left ventricular hypertrophy. So we always get a baseline echo on our kids that do have hypertension. LVH is just thickening of the muscle of the left ventricle of the heart. It's present in about 30% of obese children with hypertension. So that's why we go ahead and get that baseline. So we have several kids that already have LVH by the time that they get to me. So they've had elevated blood pressure. So it can take a while to get into our clinic sometime, or it just they haven't known they've had elevated blood pressure because they're not necessarily looking at the NHLBI charts. And so when they get to us, we're doing a baseline echo, and we're seeing some mild LVH. And that's an independent risk factor for cardiovascular disease as well. So then, essentially, obesity in childhood is a very consistent predictor of adult heart disease. So I think the point that I like to make is this doesn't just happen years down the road, although we know it tracks into adulthood. We're seeing it right now. And so if we can, I'm a pediatrician because I wanted to be involved in prevention. And so, I think if we can make an impact now, then that's what we need to do rather than wait. But these 4 studies listed here, the Bogalusa Heart Study, the Muscatine Study, the CDAH, and the Young Finn Study, all have tracked kids longitudinally who were obese and looked at what cardiovascular risk factors they had in childhood and looked to see how that tracked into adulthood. And so it is consistently correlated that on longitudinal studies to say, hey, these obese kids had X amount of cardiovascular risk factors, and this puts them at risk for the MIs, earlier and earlier stroke, et cetera. And as I think Dr. Rose had pointed out that, the Bogalusa Heart Study says this starts early. So obesity is an inflammatory state. You're starting to get plaques and disruptions in your aorta and your coronary arteries, as young as 5 to 15. So I do feel like this is, it is our job to stop this process because by 24, if it looks like that, that's not good going into adulthood. So it's also, it's the biggest predictor of increased rate of death, so cardiovascular disease. So really managing that dyslipidemia and hypertension and obesity in childhood to help prevent against premature death. And then finally, I think we have to mention the psychosocial factors because those are so common and prevalent, and just making sure that we're looking at all the kind of psychological morbidity. We're screening for depression and anxiety. We're talking to parents about low self-esteem. I'll say that a lot of times, so when I have my first visit in the multidisciplinary clinic, I'll ask the mom, and our families are prepped. We have pretty strict referral criteria, and they've talked with our program coordinator at least 2 or 3 times before they come in to the clinic, and so that helps with our no-show rate. In 3 years, we've had 3 no-shows, which is pretty amazing for a new patient visit. But at the same time, a lot of our patients will say, the moms will say, I'm worried about her self-esteem. We have questionnaires, and they're like, I'm doing this because I want to help her self-esteem. So I think that's what we focus on. That's something, how can we do, where is she at right now? How do you feel like she is now? How can we build her? And that's bringing the kid into the conversation too, as Dr. Gillespie was saying, how we build the efficacy for them. Always want to address the teasing and bullying. I've had kids that homeschool because of it. So they were teased or bullied in public, in their school, and so they are homeschooling them now. And it's a huge problem. And so screening for that in primary care, I think, is important. And also looking for any potential eating disorders as well, because all of these impair the quality of life. And so there's validated questionnaires that you can use. The BASC for, but I think more commonly in pediatrics practice is the PEDS quality of life. Do any of y'all use the PEDS QL? Anyone? Nope. Okay. So the PEDS QL is a pretty simple screening questionnaire that can tease out some of this, and then referring on to some psychological services. So again, just remembering to do that review of systems and doing a thorough exam and going ahead and doing that lab exam. I didn't talk about about the TSH or the vitamin D or what's the other one Dr. Rose mentioned? Cortisol. So there's a big debate about what all labs we should really do, and there's a debate amongst us that are doing this on a daily basis as well. And so, I feel pretty strongly. TSH. I feel a lot of so I trained in like 4 different weight management clinics, and all of them did TSH. But everyone was like, we don't need TSH. And so again, it's kind of what Dr. Bowling said. It's if the parent's really concerned about that, then maybe just kind of taking that off the agenda for them. But at the same time, I don't do it on a regular basis. I look if they're short stature and there's a family history, then yes, I'll look into it. But I am not doing it on a routine basis. Vitamin D, I'm only doing in selected populations. We know that vitamin D deficiency is associated with obesity as well as a lot of the comorbidities. It's variable as far as which clinics are doing it. For primary care, it's not a recommended lab at this point in time, at least. These are really, so A1C is now on this list. It was not when the recommendations came out, but really, these are the main recommended labs. And then, obviously, as indicated by review systems, our physical exam as we talked about. So here are the resources I mentioned, the Children's Hospital Association consensus statements, and it covers the lipid abnormalities, the abnormal liver enzymes, hypertension, and polycystic ovarian syndrome, and it gives algorithms for both kind of diagnosis and management. And that came out, a year or 2 ago. And then the NHLBI expert panel on integrated guidelines for cardiovascular health and risk reduction. So that's the website for the NHLBI website. There's also an article, there's a supplement in pediatrics for it that's in my references. So having those are really the only 2 guidelines that I know, that I'm aware of on how to manage kind of chronic comorbidities. I think it's really, working in the different weight management clinics, it was really kind of what the subspecialist at that institution wanted. So it was guided a lot by what's available at your own institution as well. I think the reason the consensus focused on these are things that, you can be treating in primary care practice and not necessarily needing a referral. And so that's why they had put out that consensus statement there. So that it's not dependent if your subspecialist is 2 hours away or an hour away, that you could go ahead and be doing the management in your primary care clinic. And that's probably more familiar to y'all as family physicians anyway it's pretty foreign to pediatricians, but maybe much more comfortable for those of you that are family practice. So just key points are to promptly identify obesity comorbidities requiring immediate attention, and I've listed those there, as well as evaluating for chronic comorbidities on a regular basis, especially for a child with continued weight gain. So I didn't talk about the frequency of repeating the labs. The 2007 recommendations had said kind of to do that every 2 years, but if you have if they're continuing to have pretty rapid weight gain, then I think more frequent is probably appropriate. In our weight management clinic, we do it every 6 months. Again, most of these are coming in with abnormal labs, so I'm wanting to provide them feedback, and we're seeing improvement on those labs, so I want to make sure that they're they're seeing the outcome. That being said, I continue to do it. So if their triglycerides go normal, then I'm still going to repeat that because we see fluctuations, right? So we talked about the stages of change and how people can, make efforts and then kind of backtrack on those efforts. We see a lot of Latino patients in our clinic, and they all seem to go to Mexico for a month over Christmas, and they go in the summer, and so it's like everything is taken off the table. They're back to sugary drinks, and so we have to spend with some of our families 2 years down the road where they're taking like a suitcase of healthy foods down there, or trying to figure out how to manage that a little bit better. But there's backtracking, and so I think it's important to follow those. So we repeat them every 6 months, and just that. All of these, the key theme here was what was the management. It's all diet and activity management. And that these are still reversible at this stage. And so that's why it's key to addressing these now and looking for these now and having that whole family engaged. With the mom saying, oh, but they spend all their time at grandmother's house and she's not going to change what she's doing, it's fine if I change it here, bringing them in and talking about the child's health, and here's what we're already seeing for his age and what the health risks are, and here's what his labs are. They're like, okay, well, this is about their health. I'm going to maybe work and make some changes as well for them. So referring to community resources, I think, is absolutely critical. Dr. Bowling talked about that as well. We don't, there's pretty limited what we can do in the clinic. It all is based on kind of what their environment is and where they live. And so connecting the family with community resources and then referring to specialty clinics for further evaluation and management. It does sound like y'all have a stage 3 clinic somewhat nearby, maybe an hour nearby. The high BMI clinic that Dr. Rose talked about. Lexington. And then do they come down from Cincinnati as well? So there's a couple of resources for doing kind of more, for referring out. So, and those are my references. Thank you. Any questions about any of that? Y'all all know it.